I'm just going to ask that we dive right in. I wanted to be clear about a couple things up front, and that is that, first of all, neither Neil or I have any financial stake in this conversation. And I just wanted to make sure you know what Neil and I know about Leronlimab for the treatment of COVID, particularly focusing on critical COVID.
Okay.
And I want to start by saying that this is a CCR5 monoclonal antibody formerly known as Progenics 140. It's the only drug in development at Cytidine. And I want to frame this conversation by saying a couple things about Cytidine. I think you'll see that after only 2 studies, Cytidine has generated some fairly compelling data, which I would characterize as hypothesis-generating phase 2 data, and really quite exciting, particularly in the critical population. And they did that after only 2 studies in a new disease. So that's sort of on the plus side. On the minus side, this is the most inept company I've ever dealt with. I've been an investigator on around 300 studies, probably 50 companies, and they hands down win the prize as the most ineffectual group ever. Their CEO, he's got no medical training, no training in drug development. He's a terrible communicator, and most importantly, he doesn't listen. And so this is an exciting, I think, data set generated after only 2 studies, but it took 2 years to get here. By the time they get this right, we may be well through the Greek alphabet. So that's sort of as background. So they are developing leronlimab and trying to cure everything. They do have a phase 3 study in HIV, highly treatment-experienced patients with a significant p-value. They've been trying to prepare a BLA for about 3 years now, unsuccessfully, but we know the drug works in HIV as a competitive inhibitor of CCR5, blocking viral entry. But that doesn't necessarily mean that it's going to work in the rest of these indications, all of which sort of depend on the biology of CCR5 and the role CCR5 plays either in the tumor microenvironment or in inflammation. So various cancers, graft versus host, NASH, COVID, as well as long COVID. And that's part of the problem, is this tiny company, which 3 years ago was a penny stock, is trying to solve all the major medical problems of the world and not doing a particularly good job with any of it. The drug is administered as weekly sub-Q injections. So each injection is 2 mLs of 350 milligrams. So 1 ml is 175. And that is an arbitrary amount of drug. There's never been a dose escalation study. As you'll see from the safety data, there's no maximally tolerated dose defined. For a long time, they were using 350 milligrams once a week on the assumption that 1 ml sub-Q was the maximal volume tolerable. During our HIV monotherapy projects, I kept pushing the dose first to 525 and then to 700. And as you'll see, there have been no safety signals. So no MTD. Safety overall, again, over 1,200 patients exposed. That's HIV, cancer, and COVID, and no consistent safety signal. The advantages of leronlimab versus the other CCR5 antagonists: it's a humanized IgG4 to CCR5 that prevents the CCL5-induced, Rantes-induced chemotaxis of inflammatory CCR5 positive cells, and that would include both Tregs, preventing Tregs from getting into the lungs to suppress the innate immune system, as well as the migration of other pro-inflammatory cells, which then in turn would secrete more Rantes and create this vicious cycle of cytokine storm. Therefore, and it remains to be proven, but it's possible that blocking CCR5 could be effective in a variety of different medical conditions, pathologies involving this pathway. And importantly for this conversation then, if the drug works, it's irrespective of the variant, because we're not talking about a viral-specific approach. But the whole point of our conversation today is that as a competitive inhibitor of CCR5, leronlimab is meant to block downstream action of Rantes. So this is data from Olson and others published when they were with Progenics, and they're looking at 6 different monoclonal antibodies on the left. And PA14 becomes Pro-140 and now leronlimab. And PA14 was chosen because of its IC50 for HIV preventing viral entry, 0.024 microgram per ml. And when you give a dose of of 700 milligrams sub-Q. First of all, it takes a day or more like 2 to reach the time to maximal concentration, and you're more in the range of 27 micrograms per ml. So using sub-Q dosing well in excess of what's needed for blocking of HIV entry, and that's confirmed in the phase 3 studies. And in earlier studies, we saw that Pro 140 had about a 1.5 log reduction in HIV viral load when given as a monotherapy. The issue is the column on the right, calcium flux, which is a marker of the binding and downstream action of RANTES. And you see that the IC50 for blocking RANTES is about 1,000-fold higher than what's needed to block HIV. And that's an observation that's been completely ignored by Cytidine. Again, when you give a 700 milligram sub-Q dose of Leronlimab, you can get about 27 micrograms per ml, so something less than the IC50 described in this work. And again, it takes 2 days to get that receptor, that maximal concentration. And when you give it IV at similar 10 milligram per kilogram dose, you can get about 200 microgram per ml. So for the rest of this presentation, one of the things I'd like you to understand is that whatever data I'm about to show you is data that actually has been generated using what is likely to be suboptimal dosing of the drug based on these IC50s. Not only suboptimal dosing, but suboptimally delivered, sub-Q as opposed to IV, and as you'll see in a moment, suboptimally dosed for duration. So that's the context in which I'm afraid the rest of this data needs to be understood in. So I think Bruce Patterson deserves a lot of credit for pushing the idea that Leronlimab could work in critical COVID. And it's all about RANTES, blocking the action, the respiratory epithelium, getting infected, secreting RANTES, and having that gradient drive chemotaxis, pro-inflammatory cells into the lungs, which then amplify the signal. And obviously, in the case of hyperinflammation, critically ill patients, a cytokine storm that is often fatal. So in my email to you, I had attached 3 published manuscripts. And by far, I think the most important is from Bruce Patterson. Bruce got the idea that Leronlimab could work in COVID. And then that idea spread out, included Otto Yang at UCLA, who has a paper that I asked you to look at, and Harish Sithamraju at the time Montefiore Einstein, where my father still works to this day. And so Harish and Otto contacted the FDA and requested a number of emergency IND applications for their patients. And so these data are derived from 10 patients that were under Harish's care in the ICU at Montefiore. And these patients were quite ill. They were mostly intubated, they were mostly on pressors, they were mostly on dialysis. Several had liver failure. The survival, I think 6 of the 10 survived out to day 14, but overall survival was not great. And these data have not been replicated anywhere because after some period of time, Cytidine severed their relationship with Bruce and in the middle of their phase 3 studies and didn't have a backup lab to generate, confirmatory results. But this is what Bruce showed in those 10 patients, that at baseline, they had elevated levels of various inflammatory cytokines, IL-1 beta, IL-8, IL-6, but the common denominator among the 10 patients was sky-high RANTES levels, from 10 to 200 times normal levels. And Bruce separately has generated data, I believe, showing that these RANTES levels are much lower in patients with mild to moderate disease and obviously normal in patients without COVID. So I got a phone call from Bruce on April 9th, coming on 2 years now, saying, Jay, COVID-19 is a RANTES disease. And specifically, Bruce showed us that even though CCL5 was elevated in these patients, that MIP1 alpha, MIP1 beta were not. So that it was really fairly specifically RANTES. And then this is kind of the key slide from Bruce, showing that in the patients who got, again, sub-Q Leronlimab, dosed sub-Q instead of IV, with a potentially suboptimal dose, only 2 doses. It's all the FDA would allow. That he showed by a dose at day 0 and day 7, and has data from day 3, 7, and 14 showing uniform decreases in IL-6, that these patients all had a severe CD8 immune suppression at baseline, which fairly rapidly reversed with increasing CD8 counts, normalization of the CD4-CD8 ratio, all of which correlated statistically with increasing receptor occupancy in both T cells and monocytes, which reached 100% by Bruce's assay by day 7. And that he also showed that using a digital droplet PCR technology, that there was a decrease in plasma viremia in these patients that also correlated with the increase in CD8 counts. It's a small sample, obviously, 10. So I think it's a little hard to read out the clinical outcomes in those 10 patients. And I would feel better if those laboratory data had been replicated in a follow-up study of other ICU patients and at another lab. I think Harris's cohort of 10 were on death's door, and I think those people died providing us samples to generate a signal, assuming that Bruce's data is real. And then, Otto had 30 patients on the EIND program. Unfortunately, he was not able to send blood to Bruce's lab, but Bruce's data is suggesting really fairly dramatic day 3 responses in laboratory metrics, obviously. And Otto, his experience with the EIND program was similar, that the patients who responded, particularly some who responded after their second dose, responded very rapidly. And so he's become a believer as well. And I quoted something that he had said to me in the email I sent, that if one day Leronlimab is actually shown to work in these patients, the question won't be why it works, but why it doesn't work in everybody. Because clearly it doesn't. But it's my bias that it works in many, if not most, of these patients. And so Otto's paper is absolutely worth the read. And I will only introduce one anecdote into this conversation, but it's an anecdote that Neil helped me with, and it's striking. This is a patient who was in London in his late 50s, who was hospitalized with COVID, was intubated for 19 days, and then was placed on ECMO for 2 months. His wife is a physician in London, and she called me, and she said, how can we get him, Tundi, his name was, how can we get Tundi Leronlimab? And we did, and consistent with Bruce's data. Tundi got his first dose of Leronlimab after 2 months of ECMO and 79 days in the ICU, and he started weaning off of ECMO 3 days later, and ultimately was able to get discharged from the ECMO unit, and then unfortunately had a massive MI during his rehab and never left the hospital, which was a heartbreak for everybody, including this incredibly devoted wife. But I offer this, it's an anecdote, but it's a striking anecdote of an example of where Leronlimab seems to work. It works pretty quickly. All right, so we'll go into the randomized clinical data now. And the first trial was CD10. And so March of 2020 comes along, and obviously COVID blows up. At the time, I'm doing HIV and cancer studies with Cytidine. I'd met with FDA and Cytidine 3 occasions face-to-face. So I got to know the antiviral group, Jeff Murray et al., pretty well. Cytidine submits a proposal to do randomized studies in COVID, and FDA puts them on clinical hold and says, we don't even want to talk to you for 60 days. Obviously, they're being inundated with hydroxychloroquine and plasma and remdesivir and Trump, and they have no idea why Cytidine thinks this would be even plausible as a good idea. So they're on clinical hold. I had a conversation with Nader. I said, Nader, you really need a chief medical officer. And he said, well, you do it. So I became their interim chief medical officer for about 2 months, March and April, until the chairman of the board took over as their CMO, which is why I kind of know what actually happened here. So they were on clinical hold, and I spoke with Jeff Murray. And Jeff said to me, Jay, why don't you do something useful and work on good, antiviral therapy for COVID? And what I said to Jeff was, Jeff, we worked on oseltamivir and zanamivir. In those studies, and I'm showing data here from Rich Whitley, that you can reduce viral loads and viral shedding by several days with these good antivirals, but you actually don't change the course of the illness, and you certainly don't change it unless you get in very early. You don't change it that much. So I convinced Jeff that, I thought we were going to need something to deal with immune dysregulation, and that leronlimab might have a role here. So they said, okay, you can have CD10, which was a phase 2 randomized double-blind placebo in mild to moderate illness. So one of their concerns, besides the fact that they fundamentally didn't understand or believe that leronlimab would have any role in this illness, one of their concerns was the possible immunosuppression that might come with CCR5 blockade. So they gave cytidine CD10, a study that, after all that I've already said, obviously is targeting the wrong population and obviously is underpowered to show anything at 85 patients enrolled. Subsequently, they allowed CD12, which is really where the meat of this is, and we'll get into that shortly. So CD10, the primary endpoint, was taken right out of the influenza playbook. We used 4 clinical symptoms: fever, myalgias, a cough. I mean, things that really are not that relevant to COVID, especially myalgias. And the primary endpoint, of course, given the size of the sample and the population, showed no difference between leronlimab and placebo in the total symptom score at day 3. But I would point out that half of these patients had no or minimal symptoms at baseline. And CD10 again showed the safety of the drug, but there are a couple of downstream signals that I think are relevant to the conversation. The first is the NEWS2, the National Early Warning Score from the Royal College of Physicians in London, which was a predefined secondary endpoint, and predicts who's going to have pulmonary collapse. And in the modified intent to treat, 84 patients at day 14, patients on leronlimab were more than twice as likely to experience improvement in NEWS2 compared to placebo, 50 versus 20%, p-value 0.02. And this is relevant. Leronlimab may not help with your muscle aches when you first get infected, but it may in fact slow down the immune dysregulation that could be impacting some people down the road. There are also a statistically significant improvement in NEWS2 in the per protocol population at both day 3 and day 14. So I do think that's an interesting, provocative signal, not anything that you could go to the bank over. And then if you look at AEs, SAEs, and hospitalization, the incidence, frequency, and severity of both AEs and SAEs were lower in the leronlimab group compared to placebo. And I do think that's an interesting downstream signal. There were 30% fewer AEs and 63% fewer SAEs. FDA's response to that is that cytidine got lucky. And that may well be, but I think, again, it's provocative. And then finally, the patients on leronlimab actually had an 83% decreased incidence of subsequent hospitalization compared to placebo. So again, CD10, wrong population, small study. It's what FDA would allow cytidine to do, given their lack of belief that there was any relevance of the drug to the disease state, and their concern about immunosuppression. But once CD10 started enrolling, and then, I don't know, things got bleak, maybe they got tired of hearing from me, but they then said, okay, you can have CD12. And so this is really what it's all about and why we're on the call today. So CD12 was a phase 2b/3 randomized double-blind study of leronlimab in patients with severe or critical COVID-19. Now, there was a mistake that I was part of, that we took Bruce's lab data, Otto's experience in the ICU, and we made an assumption that if it was in fact working in critically ill patients, that it ought to provide benefit in patients who were in the hospital on oxygen but not yet intubated. And that may be true, but it's going to require separate studies and much larger studies. So what FDA allowed and what sort of Cytidine could imagine and afford was about a 400-patient study, randomized 2-to-1 in combination with standard of care. The modified intent to treat population is 384, and then leronlimab is dosed again 700 milligrams or placebo sub-Q day 0 and 7. The story there is that Bruce, Otto, and I all told Donner, the CEO, that the CD12 study needs to administer the drug 4 times, day 0, 7, 14, and 21. The reasons for that are A, it's patently ridiculous to be giving patients at home with the sniffles the same dose that you're giving a patient who's intubated in the ICU. But more importantly, and this is not data that's in Bruce's paper, but he was able to show that some of these ICU patients had elevated RANTES levels out beyond day 14. So there's nothing about leronlimab that directly inhibits production of RANTES. I mean, downstream, if you have fewer pro-inflammatory cells in the lungs secreting RANTES, eventually your levels will come down. But it's not like the same effect you would have on IL-6 or potentially CD8. And so there were patients who needed more dosing beyond day 7. Unfortunately, the FDA pushed back, and again, I think out of concerns about immunosuppression, lack of understanding about the drug. Basically, they had framed it as an acute viral illness and said there's no reason to dose these patients beyond day 7. And, I've tried to live my life without regret, but one of my great regrets is not raising a bigger stink about this. Not that anybody was listening to me anyway. So dosed day 0 and day 7, and as I said previously, potentially underdosed and potentially dosed through the wrong route, sub-Q versus IV. But Nader was not interested. He was unwilling to do a dose escalation study prior to the phase 3, and he was not willing to entertain IV dosing in these ICU patients. So here's the population. It's using the ordinal scale. It's the reverse of all the other companies. So OS2 is in the ICU, intubated or on ECMO. 3 and 4 is in the hospital on oxygen, and 6 is ready for discharge. So the study initially did not allow concomitant use of other COVID therapies and was initially restricted to patients under 65 years of age. After 2 months of very slow enrollment, during which time FDA received about 100 emergency IND applications, which they found extremely annoying, we got 2 emergency phone calls in May. The first was, we're shutting down the EIND program. It's taking too much time. It's too much paperwork. And they were particularly peeved about the fact that Otto had 30 patients enrolled on the EIND program, but only 2 in the randomized clinical studies. And Otto was in LA. He had a lot of high-profile Hollywood individuals, so he was able to just keep getting them leronlimab, and he did. He's a great doctor. Did what I would have done. But it really upset FDA, so they shut down the EIND program, and then they call us a week later, and they say, we need to redo your inclusion criteria to get this study enrolled. And at that point, they allowed all of the COVID therapies, IL-6, plasma, remdesivir, hydroxychloroquine, whatever. And then toward the end of the call, they said, what else can we do? And the CRO, which has been part of the problem here, said, well, the EIND data, which I'm not sharing with you today, suggests that age is not that huge a factor, that we've seen older patients than 65 respond to leronlimab. So FDA said, okay, let's just get rid of the age restriction, which was fine, except for the CRO did not then stratify for age going forward. And although during the DSMC interim analysis at 50% enrollment, it may be that the age was distributed equally, as you'll see in a moment, at the end of the day, Cytidine got clobbered with an imbalance on age. The primary endpoint was day 28. So when we submitted the protocol with 4 doses, that made sense. Everybody was using day 28. When FDA said, no, you can only dose to day 7, the endpoint should have been day 14. But they made CytoDyn stick with the day 28 mortality endpoint. The secondary endpoints were category 6 or higher at day 28, change in clinical status on the ordinal scale, and the length of the hospital stay. So the baseline demographics, the only thing I want to draw your attention to is age. You can see that there are about 90 patients over 65 on Leronlimab and about 30 on placebo. So a 3-to-1 randomization. So again, luck of the draw, not stratifying. They ended up with a terrible imbalance. And that imbalance, the mortality rate in patients who were over 65 was 3.5 times higher compared to under 65. So between the imbalance and the higher mortality rate, that did not help their situation. So the analysis we're going to show you is the modified intent to treat, 384, and then looking at subgroups over and less than 65. So in terms of the primary endpoint, mortality at day 28, there was a 1.1% reduction, absolute 5.3% relative reduction. That benefit was more pronounced in the less than 65 years of age. And we're almost done. On the left will be the modified intent to treat, greater and less than 65 years of age. And on the right is going to be the ICU population. There were a total of 62 of them, and that'll be broken down into greater or less than 65 as well. So again, back on the left in the MITT population, a delta of 1.1, a relative delta of 5.3, with a p-value for the overall study of 0.23. The data actually on the right has not been updated. I don't actually interact with CytoDyn all that frequently, and when I do, it tends not to be terribly productive. But these data are actually not accurate. The relative data at day 28 in the critical population is actually 31%. And again, it looks a little bit more like the benefit pertains to those who are under 65. After about 4 or 6 weeks of stumbling around, someone finally got around to looking at the mortality at day 14. And that was kind of eye-popping because that's when patients were getting the drug and presumably had close to 100% receptor occupancy. And what we see there is that the delta was over 20% with a relative benefit in mortality of 82%. And if those numbers were to hold up in a follow-up, larger, statistically significant phase 3 study, that would mean that the number needed to treat was less than 5. And again, the day 28 relative delta is not 24%, it's 31%. There was one reason why I wanted to speak to you today. It was to make sure you saw this slide, okay? This is a drilling down on what the actual numbers were at day 14. So 2 of 43 patients on leronlimab plus standard of care versus 5 of 19. Small numbers, but odds ratio of 0.09, confidence interval doesn't cross 1, p-value of 0.023. And then as part of it, most of what we do is phase 1-2, so often looking for evidence of proof of concept wherever we can find it. And this is another arrow pointing in the direction, trying to tell us something, I think, where the relative reduction in mortality was 78% and 82% at day 7 and 14, while we're giving the drug and seeing receptor occupancy. And then we're withholding the drug and following them at day 21 and 28, and we see a return, a gradual loss of that mortality benefit. Certainly, again, not something you can get a drug approval based on. I felt personally that this was enough for an EUA given the paucity of therapeutics for the ICU population. FDA didn't see it that way. But, certainly, again, is provocative. All right, I'll go through the rest of it pretty quickly. This is all-cause mortality. Again, the FDA allowed all these concomitant COVID therapies. And in that modified intent to treat population, the relative decrease in mortality was 28% with a p-value of 0.03. I realize that all these p-values are kind of meaningless in a context where you miss your primary endpoint. But, they are all meaningless statistically, but, in the middle of a lethal pandemic when we're looking for clinically, impactful therapies, I'm not sure that meaningless is the right word. Again, we see that the blues do better than the reds, particularly in the less than 65. And over on the right, you can see that, blues are doing better than reds in the critical population, and again, more so in the less than 65. And this now includes monoclonals, dexamethasone, remdesivir, plasma, the IL-6 drugs. And then, particularly just looking at dexamethasone, so the last slide suggests that leronlimab plus anything that has antiviral activity in the COVID setting is better than that therapy plus placebo. And then what this slide is suggesting is that leronlimab plus dexamethasone is better than dexamethasone alone. In the modified intent to treat population, you have a p-value of 0.05. So it would appear that leronlimab plus either an antiviral or dexamethasone is better than any of those therapies plus placebo. This is change in clinical status at day 14 and 28 using the ordinal scale. Again, blues are doing better than reds, and p-values are p-values. This is discharged alive, and again, blues are doing better than reds across the board. Importantly, if you look at the in that box, that last line, in the critical population, 28% of the folks who had been intubated at baseline were discharged from the hospital by day 28 with leronlimab, compared to only 11% on placebo. P-value of 0.08. 160% more likely to leave the hospital by day 28. For those who like to use discharge from the hospital as your primary endpoint, this is the change in clinical status using a 7-point scale again. Again, the blues are doing better than the reds. Then I believe remdesivir was approved based on length of hospital stay. In the ICU population, there was a reduction in the length of hospital stay by about 5.5 days with a p-value of 0.005. The safety data, I don't find anything particularly compelling about it, but to say that, again, there's no new signal with leronlimab in this population. There doesn't seem to be cause for concern around immunosuppression, and I still believe that there's room to actually increase the dose if that was useful. So overall, the day 28 mortality, there seemed to be a signal in patients who had received any standard of care or concomitant COVID therapy. There seemed to be some benefit in patients who got dexamethasone plus leronlimab versus dexamethasone alone. There seemed to be a decrease in the length of hospitalization in the ICU population by 5.5 days, and probability of being discharged alive at day 28 seemed to be true both for the modified intent to treat population as well as the ICU population. So I'm going to stop talking, and I'm going to ask Neil to address these last two slides.
Actually, all of the sort of the sound bites that I was going to say, you've already said. So, looking at this one, which is day 28 mortality, clearly an odds ratio on the left-hand side of the line is where you show that leronlimab is better than placebo. What is striking both positively and negative about this slide, what's striking positively is that the point estimates are all on the left, pretty much all on the left-hand side of the line, and are comfortably on the left-hand side of the line. But then the elephant in the living room is that the confidence intervals are enormous because the study was not powered. It was borderline probably powered for the overall analysis, which is at the very top, which shows that the point estimate is to the left of the line, but the 95% confidence interval clips the one, which obviously means that it's not statistically significant. But when you then look at the age groups, yes, the younger age groups do seem to do better than the older age groups. And I have to look at these slides statistically, but I also, you said at the beginning that you considered a lot of this was hypothesis generating. And for me, this is telling me that there is a very strong signal there, but the study was not designed to actually take that through to real numbers that people were going to say, yeah, okay, I agree, you've convinced me. We all know that if you increase the numbers in a trial like this, what you'll find is that the point estimate will generally stay fairly where it was in the smaller study. Yes, some will move, some will not move, but generally the point estimate stays where it is, but the confidence intervals will then shrink down to meet the point estimate. So this does not tell me that it's proof that the drug is working, but I'm looking at thinking, boy, this really does look like, had the trial been done slightly differently and with larger numbers, we might be talking about a completely different conclusion. So this is just looking at day 28 mortality, and the next slide is just looking at the other endpoint that Jay mentioned earlier, which was the individuals achieving category greater than or equal to 6 on day 28. And similarly, what you're seeing is that the point estimates are falling on the right-hand side of the line now because we're looking at a benefit, and Leronlimab seems to be driving a benefit in terms of those on day 28 with achieving a category greater than or equal to 6. But yet again, the confidence intervals are really quite large. And so once again, you can't say that this is proof that the drug is working. But it's when I look at a slide like this, I'm thinking, okay, in the next trial, if there is a next trial, what would I be doing differently? Jay's already mentioned the lack of stratification for age, which was frankly a big mistake, especially when we knew that older people were apparently suffering more significantly from the disease than younger individuals. The size of the trial, yes, I get that, you don't always get a Glaxo, Pfizer, Roche, Novartis 2,000 patient trial. Maybe the number was a good estimate, but with hindsight, especially with these subgroups, you would have needed bigger numbers to start to really show definitive proof, if you can call it proof, that the drug is working. So these two slides really just confirm what Jay has already described. For me, I think maybe I look at things slightly differently, but these two slides to me strike me more strongly than the histograms and the raw numbers, especially when you've seen on both these slides, this is on a logarithmic scale. So we are talking about some of these odds ratios are really quite significant and quite clinically relevant were they to be replicated in a statistically valid way. So for me, this is just reaffirming what Jay has said and makes me quite sad, if I can say that. We're in a position where instinctively from 30 years of drug development, I know when I'm looking at something and thinking, oh, this is working, or actually this is not working that well. And to me, it looks like it's working, but it hasn't cleared the bar. So thanks very much for the opportunity, Jay. As I say, just to reaffirm, if the drug doesn't work, we need to know it. Yeah. But we need to know one way or the other.
Thank you so much, Neil. Thank you for 30 years of your friendship. The other piece of information that I want you to know, and the reason that I contacted Tony was wanting this drug to either be shown to work or not work, is first of all, Omicron, and that nightmare is unfolding. But the FDA said you need to repeat the phase 3 study with much more robust numbers. And so, Cytidine is struggling financially to have the resources to do that. But they did set up 2 studies in Brazil, one for patients with severe disease and the other for patients with critical disease. And I woke up on Thanksgiving Day to find out that after 2 months of enrollment, they had enrolled 4 patients. So I'm still not particularly asking, but I want you to know that. 2 months of enrollment, 4 patients. What keeps me up at night is the ICU teams.
Yeah.
The nurses, the respiratory therapists. I don't know that there's another therapeutic in this population that's given a signal of 82% reduced mortality.
Yeah.
I mean, that's more than I expected, that's for sure. But if there was ever a situation, and if there was ever a drug, if there was ever a company that needed the help of our federal government,
yeah,
it's this one.